All right, well, we're going to go ahead and get started on tonight's webinar for AO Spine. It's post-surgical infection with spinal instrumentation. My name is Grabowski from the University of South Carolina. I'm the moderator for tonight's webinar. I have the very distinct pleasure of having two dear friends and colleagues as my guest faculty. It's actually a pretty special group for me because there are two gentlemen who I got to see grow from junior residents to their positions today. So Nick Spina is an assistant professor at the University of Utah, and Keith Lynn Jackson is at the Eisenhower Army Medical Center, where he's the residency program director in orthopedics. In terms of disclosures, all of us serve as AO Spine faculty. That's what you're seeing here. No other significant disclosures to disclose. So for an overview of what we're going to be talking about tonight, post-operative infection is an unfortunate but an inherent risk of spine surgery. Infection is in the setting of instrumentation further raises the stakes. This particular webinar is going to review the incidence, diagnosis, and treatment of post-surgical infection with spinal instrumentation. In terms of our learning objectives tonight, upon completion, participants should be able to review the published incidence of postoperative infection, including common organisms, explain the appropriate steps in diagnosis, and apply evidence-based treatment principles for patients with post-surgical infection with spinal instrumentation. For our agenda, after this welcome and introduction, we're going to shift over to Dr. Jackson, who will give an introduction to post-surgical infection of the spine. Dr. Jackson will give way to Dr. Spina, who will talk about diagnosis and imaging. And I'll close out the webinar talking about treatment options. At the end, we'll leave some time for Q&A with all of the faculty. And also, throughout the course of the webinar, I'd ask that you feel free to ask questions through the Q&A dialog box. We'll answer those questions both through the dialog box, but also while we're in between different sessions in person, we'll answer those live as well. At the end, we'll wrap up and adjourn and go from there. So without further ado, I'm going to turn the floor over to Dr. Jackson.
Thanks, Greg. I appreciate everybody joining us tonight for this discussion. One of the things we commonly do in AO webinars is we introduce an illustrative case to kind of frame the problem. And so I'll do the introduction, and then we'll talk a little bit about the about some of the economic and patient-related burdens of infection with instrumentation. We'll then go into some of the microbiology, and then we'll talk about risk factors and ultimately preventive strategies. So to start off with a case, this is a let me get back to the first one. This is a 72-year-old female who was treated by an outside surgeon with an L1 to the ilium decompression and posterior spinal fusion with stainless steel instrumentation and allograft interbody devices at L4-5 and L5-S1. She had a past medical history significant for hypertension, hyperlipidemia, atrial fibrillation, and hypothyroidism. She was discharged to a specialized nursing facility after a routine hospitalization. Unfortunately, at about 2 weeks after surgery, she developed a draining wound. She then transferred to the emergency department. There, she was found to be afebrile with a relatively normal WAC count and a relatively normal heart rate. However, her CRP was 281. With a presumptive diagnosis of acute or early postoperative infection, she was taken back to the operating room where gross purulence was expressed immediately upon reopening the incision. Intraoperative cultures were obtained, and she had an irrigation and debridement with 15 liters of normal saline. As per the outside treating surgeon's practice, she was temporarily closed over a betadine soaked sponge. The area was reprepped and redraped, and new sterile instruments were brought in, and she underwent primary closure. Empirically, she was started on intravenous vancomycin and Zosyn. Ultimately, her blood cultures from admission grew out MRSA. Intraoperative cultures grew MRSA and Prevotella. She was transitioned to IV Vancomycin, Flagyl, and Rifampin for a total of 6 weeks, and then transitioned to oral Bactrim. And her CRP initially responded. It went from 281 to 37 at 3 weeks. Unfortunately, 3 months into the course of antibiotics, it remained elevated at 40. Post-operative instrumentation, post-operative infection in the presence of instrumentation is a common clinical problem faced by most practicing spine surgeons. We currently instrument in a lot of different ways in a lot of different areas through different approaches. So the range actually varies quite widely, anywhere from 0.014% in things like ACDF and lateral interbody devices up to 20% in posterior approaches for multi-level adult deformity cases or fusions for malignancy. The rate of infection depends on things on variables like approach, the number of levels fused, or the magnitude of the surgery, specific patient factors, which we'll get into, as well as surgery-related factors. However, in the most common application of fusion from most people's practice is probably degenerative 1 to 2 level lumbar procedures. And the infection rate in those specific cases are about 2.5 to 8% in the reported literature. So it's something that we do commonly encounter, unfortunately. Infection in the presence of instrumentation has a large economic burden on both the healthcare system as well as the individual patient. It is associated with about 10 extra days in the hospital and excess cost in the tens of thousands of dollars. Not only is it costly from an economic standpoint, but it also directly affects patient-related outcomes. These patients have higher rates of post-operative pain 2 years after surgery. They're less likely to achieve clinically important improvement in objective outcome measures. They are about 4 times as likely to report dissatisfaction with surgery at the 2-year point. And perhaps more importantly, they have significantly higher mortality rates at 1, 2, and 5 years after surgery. In the Casper article that's quoted, at 5 years, patients who have had an infection in the presence of instrumentation have about a 5 times higher mortality rate. So this is a pretty significant hit for the patient. Some of the things that increase the susceptibility of the patient to infection when we're performing instrumentation is the wider exposure that's needed. This decreases the local blood supply. It also increases the potential dead space. Many times we're performing fusions in these applications, and we're placing non-viable bone graft or bone graft extender, which can serve as a nidus for bacterial growth. We frequently need to, when these do occur, they can be difficult to eradicate because of the frequent need to retain the hardware. Many of the indications for these surgeries or the decompressions that were performed in the surgery are destabilizing, and because of that, we have to maintain hardware. Many of the bacteria that we face can then form a biofilm that can make it more challenging to both identify and eradicate the bacteria. When we talk about infections, we typically break them up into 2 categories. That's acute and late. Acute infections occur within 21 days of the index procedure. And they're more commonly due to more virulent organisms such as Staph aureus, beta hemolytic streptococci, or aerobic gram-negatives. While Staph aureus is the most common organism in these acute infections, as we move further into the age of antibiotics, we're seeing an increasing incidence of gram-negative bacteria such as E. coli, Enterobacter, and Acinetobacter, as well as Pseudomonas species. And that's probably because we're selecting these out in both our ANSEF that we give perioperatively intravenously, or some of the topical antibiotics that we apply locally. It should be noted, however, that similar to our case, 10 to 50% of acute infections are currently polymicrobial. Delayed infections occur greater than 21 days after the index procedure. While staph species are still the most common organism, less virulent organisms tend to be found a little at higher rates. Things like staph epidermidis or micrococcus species. In the last couple of years, we've really gained an awareness of Propionibacter agnes as a culprit for many of these late infections. These, because they're less virulent and the opportunity for the biofilm to form has occurred, these can often be harder to actually get a positive culture to guide antibiotic treatment. The reported rates of culture negativity in washouts or interoperative cultures is anywhere from 16 to 80%. This for this reason, surgeons should consider holding their intraoperative cultures longer than the 72-hour period that we typically do in most other applications. The quoted or the cited paper below is an article from Spine. Clark published a review of scoliosis cases that were complicated by infection, and in the first half he held the cultures for the standard 72 hours and had a culture positive rate of about 10%. When he held the cultures for 7 to 10 days, the culture positive rate went up to about 90%. So it's important to let these more indolent organisms grow a little longer. I added the 14-day window because of Propionibacter. We know that this is an indolent organism, and it typically does take a much longer time in the lab to culture out. When we look at patient risk factors, a recent meta-analysis found 13 significant risk factors for the development of surgical site infection after spine surgery. These include things such as patient comorbidities, diabetes, obesity, revision procedures, smoking status, urinary tract infections, transfusion of blood, durotomies, blood loss during surgery, as well as patient age. Other specific patient risk factors that have been correlated with higher rates of postoperative infection include malignancy, poor nutritional status, preoperative bacterial colonization, and the use of immunosuppressive medications around the time of surgery. When we get into the surgery-related risk factors, by and away, the two largest determinants of the infectious risk are the approach as well as the number of levels instrumented. The approach, we know that lateral or anterior approaches tend to have lower infection rates than standard open posterior approaches. As the number of levels increases, the magnitude of surgery also increases. The amount of time that the instruments are open and can become contaminated increases, the blood loss increases, the risk of transfusion increases, and the dead space created also enlarges. The timing and administration of perioperative antibiotics, we know that in multiple applications of surgery, the failure to give antibiotics within 1 hour of incision is associated with significantly higher rates of infection. Operative time greater than 5 hours has also been correlated with a higher risk of infection. The use of blood transfusion in the perioperative period has also been correlated. This is probably due to higher blood losses in surgery, triggering the transfusion, as well as a slight immunosuppressive effect from donor blood. Then there's an interesting line of research on bacterial adherence to commonly used materials. Staph aureus is the most common pathogen in both acute or late infections, and it binds or adheres preferentially to different types of materials. Stainless steel actually has the greatest adherence. It actually has its greatest adherence to stainless steel, followed by titanium alloy, then pure titanium and tantalum. Polyether ether ketone also has a high adherence with Staph aureus, so many of the cages that we use are also susceptible to staph adherence and biofilm formation. We're going to get into some of the prevention strategies. You know, Dr. Spina is going to talk about the diagnosis of infection, and Dr. Grabowski is going to talk about how to clear them. But really, this is the meat of, in my opinion, this is the meat of the talk. Because if we can prevent infection, we can really mitigate some of the risks that we quoted or the dangers of these infections. We know that perioperative antibiotics within 1 hour of incision is associated with lower rates of infection. A robust debate currently exists over the supremacy of DuraPrep or ChloroPrep, and I would tell you that there's been no consistent literature that reports DuraPrep is better than ChloroPrep or vice versa. However, both are alcohol-based topical skin preparations, and as such, because have been shown to be superior to other types of skin preparations. So I would say that DuraPrep or ChloroPrep are probably reasonable and defensible choices. Believe it or not, changing out our gloves actually has some pretty good data, some pretty good literature about lowering the rate of infection, particularly when handling instrumentation. We also know that the operative microscope is also a common source of contamination. So changing out our gloves when handling particularly the eyepieces may significantly lower the risk of infection. There was the use of incisional wound vacs is an idea that's in the community. There was a pilot study reported recently in the Journal of Neurosurgery in high-risk patients that showed significant reductions in infection rate. It'll be interesting to see how this idea sort of matures as we get better data. The last two are probably two of the more common prevention strategies, and we're going to spend a little bit of time on each. But they're topical vancomycin powder as well as preoperative decolonization. So vancomycin powder is a little bit of a debatable topic right now. It really came into the forefront in probably around 2010 and 2011 when several large observational retrospective studies reported potential significant reductions in post-operative infections in both spine and many other fields of surgery. Most of these papers call for better designed or more highly powered studies in the future. Unfortunately, as these studies have been produced, it's called into question the actual efficacy of vancomycin. I quoted this article from the Spine Journal in 2018, which was a propensity scored matched analysis. It was on my longitudinal assessment from the AVOS, and basically it showed no differences in surgical site infection in patients who had vancomycin placed in their wound compared to those who didn't. It did show some protective benefit from gram-positive surgical site infections. So while the debate over the efficacy of vancomycin powder is ongoing, it should be noted that topical vancomycin has a low but present risk profile. There have been several reports of systemic reactions in patients. We also know that there also is a lot of thought that this can select out some of the gram-negative bacteria, and at least in rat studies at high doses, this can affect the fusion mass. So while we determine the role of topical vancomycin powder, we should always keep in mind that it does have a risk. Preoperative decolonization is another frequently employed method of preventing infection. We do this because staph species are the most common culprits for these postoperative infections, and they're also frequently found in the population that's getting ready to undergo elective orthopedic or neurosurgical procedures, with about 4.4% of people being carriers of MRSA on nasal swabs. The meta-analysis that I lost my slides. The meta-analysis that is quoted from the Spine Journal, reviewed all the primary literature and found that patients with MRSA colonization have increased rates of overall surgical site postoperative infection, as well as MRSA positive postoperative infections. In studies that performed preoperative decolonization, the rates of infection were substantially lower. For that reason, there is both where you can infer that there's a higher rate of infection in MRSA carriers, and that this can be mitigated by preoperative decolonization. So with that, I'm going to pass the conversation over to Dr. Spina, who's going to talk about the diagnosis of these infections.
Thanks a lot, Lynn. That was a great overview. While we're waiting for Nick to get loaded up here, just curious, what are you doing as far as your preoperative optimization at this point for patients?
So, you know, a lot of it, we're doing all the standard stuff with the history and physical, trying to pick up on immunosuppressive medications. We'll typically hold those for at least one half-life of the medication. I do a nutritional assessment in older individuals. I'm fortunate that I have a lot of younger patients in the military population who don't tend to have as many malnourished conditions. I also do nasal swabs, and I'll treat it preoperatively when we identify it, and prophylax those guys with vancomycin powder if they're MRSA positive.
And again, we'll remember that you're able to, for everybody that's participating, end up asking questions through the Q&A portal. So we're happy to be answering those either live or through the portal. So encourage those questions. So keep them coming. So
yeah, I'd be interested to hear what the attendees kind of, if they have any other takes on relatively low cost things that help with that can help in the prevention of infection.
All right. Well, I guess we will move on to the diagnosis and imaging of postoperative spine infections. I'd like to thank the AO as well as my colleagues, Dr. Grabowski and Dr. Jackson, for getting me involved. It's always an honor to be asked to talk about your own complications, something that you're good at creating and dealing with. So thanks, Greg. What we should first start talking about is that there's no clear clinical guidelines or absolute set to make a diagnosis of a surgical site infection, either in the early or late period. Surgical site infections sometimes show up and you just know that they're infected. You can take this posterior cervical wound, obvious wound dehiscence with purulent drainage coming out of the inferior aspect, and it's not really hard to make that diagnosis. That's pretty clear. Pretty much needs treatment in a relatively expeditious manner. What's harder though is when a patient calls, sends you a picture, you know, you're now at about 2 weeks out, they started having some drainage from here at the midpoint of their incision for about 3 days, really no fever, no pain control. And really the question is, well, what is this? You know, on my differential, I always kind of think about these more mild presentations. Could this just be a suture abscess, which I'm hoping for? Is it just slow wound healing with benign drainage, or does this actually represent infection? And that brings us to sort of how we can differentiate these diagnoses. And really, post-operative infection is a clinical diagnosis. And so every patient who I see or sends me one of these pictures, I bring in for an in-person evaluation. And like anything, I think the history and the physical exam is the most crucial thing. History of wound drainage is the most common presenting symptom. It happens about 2/3 of people that show up with SSI. And then we always ask about secondary constitutional symptoms: increased back pain, new neurologic symptoms, anorexia, weight loss, fever, chills, night sweats, and other things. But those are really only present in about 30% of the population. That moves us on to the physical exam, and really you want to do a thorough neurologic exam compared to your pre-op exam to note any increased weakness, increased numbness, or anything abnormal in the neurologic exam. And then it's really looking at the incision. And for me, it's the classic signs. Is there peri-wound exudate? Can I express anything? How bad is the erythema? Does it feel warm? But we're often left still with an equivocal exam. And really, if you look at this last picture, it looks kind of benign. I couldn't express anything out of it. It was cool to touch. The patient was doing pretty well, had a normal neurologic exam. And so that kind of takes us to the second step of the workup, and what else can we do? And really, we have three things that we can do. And one is looking at the timing of when the patient is coming in. The second is looking at lab work. And the third is getting imaging. And we'll kind of walk through both of these. And so in terms of lab work, kind of the gold standard and what my clinical practice, I think, is based largely on C-reactive protein and ESR. These are both acute phase reactants. CRP is probably the most sensitive. It's elevated in about 98% of postoperative surgical site infections. It's synthesized by hepatocytes. We know that after surgery, it tends to peak at 2 to 3 days and normalizes between 5 and 14 days. There's been studies that show sort of the invasiveness of the surgery, operative time, amount of blood loss, kind of insult to the patient influences both the peak as well as sort of how long it takes to recover with those surgeries that are more invasive, causing more of an inflammatory response. ESR is also helpful. It tends to peak at 2 to 5 days, but it really doesn't normalize until about 3 to 6 weeks after surgery. So for me, it's something that provides a little piece of added information, but I often hang my hat on the C-reactive protein. One of the difficult things is that we don't have anything to compare to, and C-reactive protein often comes up with any type of infection. So when you're seeing these patients in the emergency department due to fever, the question is that C-reactive protein from that or something else? And you should always use your physician hat to look for things that are common post-surgery, like pneumonia, UTI, and other sources of infection, which will also cause a raise in inflammatory markers. There's been several studies looking at other acute phase reactants in both spine surgery as well as the periprosthetic joint infection literature. Some of them that are done in spine have looked at procalcitonin. That's kind of been a hot acute phase reactant, neutrophil and lymphocyte ratio, lymphocyte count. The problem that I have really incorporating these into my practice is that these are all prospective studies that look at sort of the values of all these things at 1, 3, and 7 days in a prospectively collected cohort where their infection groups is 10 to 11 patients. And so you're generating an ROC curve or trying to set cutoffs in a very small portions of patients. And I think we get conflicting data. So in my practice, I'm not sure how to incorporate these things. I think there are other markers that can be used and are quite sensitive in some studies, and even more sensitive than CRP, depending on what you read. There's also more literature coming out about interleukin-6 and serum amyloid protein as other more accurate diagnostic markers of postoperative SSI. So, the last thing that, we always do in the workup of our postoperative patients is obtain imaging. I would tell you that generally it's not helpful in the acute setting, except for sort of catastrophic failure and these things. I do always obtain postoperative x-rays. You need a reference point, so it's important to obtain them before they leave the hospital, and especially in instrumented cases. I look for things like early failure and haloing. If you get an MRI, you're always going to see fluid collection within the first couple of weeks. Your muscles are always going to look inflamed from the surgical insult. And so it's really hard to know whether, on an IV contrast MRI, whether that inflammation means SSI or not. Any patient with new neurologic symptoms, I do always obtain an MRI to basically check my previous decompression to see if they have any compressive elements that need to be addressed if I'm going to take them back to the OR. And then finally, I always obtain a CT scan if I'm worried about hardware placement, but that's really what I'm using it for in the acute postoperative infection. So then what about timing of drainage? And do we have any guidance on sort of what type of drainage, or is there any clinical evidence to hang our hat on? Well, this was the study out of Pitt where the three of the moderators in this session have all spent time. Basically, it looked at the timing of drainage, and they took about 37 patients with AIS back to the operating room for IND secondary to drainage. what they found was that, if the drainage is happening after about 10 to 14 days, there's a much higher incidence of postoperative SSI and positive cultures than if it happens before. And so if you see a patient that comes to your clinic who's had a dry wound and increased drainage after about 2 weeks, you really have to have a heightened suspicion. But it's not a great paper, it's small numbers, and you can't really hang our hat on that sort of cutoff. I think, again, it all comes back to the clinical judgment. So getting back to this case, I obtained lab work. They had a normal ESR, a normal C-reactive protein, normal white count, no fever. Postoperative radiographs after a 3 to 5 fusion were unremarkable. I treated with close observation and followed it up in a week. Again, this brings you back to clinical diagnosis. I think you have to watch these patients closely. You have to keep an eye on it. If it is an early infection, it's going to present itself. It's likely going to get worse. I always tell these patients and give them our nurse's phone number as well as our clinic phone number to let us know which way the drainage is going to go. And so in the end, I diagnosed this as a suture abscess. It cleared up without antibiotics after about a week and dried up with just dry dressings. So then we come back to our case. This was that L1 through S1 spinal fusion and decompression with iliac fixation. And this brings us to late infection because 4 months later, this patient came back, presented to the ED complaining of low back pain, general malaise, a lot of constitutional symptoms. When we examined them, they had a normal exam, a well-healed incision. There wasn't anything concerning such as redness or frank drainage. Temp was borderline on febrile at 100.1, heart rate was 82, white count normal, but that CRP is really, really elevated. And so, obviously, we're worried about infection. And late infection principles are pretty similar to early infection. I think history and physical is still key. These patients come in with acute increased back pain. They come in not feeling great. Imaging does have a role, and we'll kind of go through the imaging of this patient and talk about it. And then finally, laboratory values are much more useful because by sort of the late time frame of 21 days, if you consider it late infection after 3 weeks, CRP really should normalize. ESR should be trending down. And if you can follow these labs, it's even better. And so I always obtain plenty radiographs anytime a patient comes to the emergency department. What you can see here, if you look closely, is you see some haloing of the L1 screws. That worries me that either they're having an early hardware failure or something else is going on. In the setting of really, really bad infection that's gas forming, you can sometimes see gas in the soft tissues. We don't see any of that here, but overall it looks relatively unremarkable other than that sort of haloing. Given that they're 4 months out, and they had a fusion operation, a CT scan was obtained. On CT, if you play with the windows, sometimes you can see a postoperative fluid collection. It's really difficult to see. I use it more for hardware placement to see if there's any obvious fracture or end plate erosions that would indicate discitis or osteomyelitis. Again, up here at L1, you can see the axial cut. You see haloing of the screws, which really should raise your diagnosis or raise your clinical suspicion that something's going on. As a side note, there's been a couple studies that have come out recently that have looked at just non-unions and culturing non-unions. And there's actually a pretty high incidence, up to 10% of these non-unions that we all have that have culture positive bacteria. And so it's potential that these low virulent organisms are causing a predisposition to non-union. I think it's something that we should all consider doing and culturing just so that we can treat it appropriately. MRI is useful in the late infection time point. If you're concerned about infection, I would always recommend getting IV contrast. It's almost classic to see a rim enhancing collection. If you see a loculated collection, that's another indication that this could be infectious. It also gives you a hint that if any of you have performed interbodies or discectomies, you can see involvement of the disc space and kind of guide your surgical treatment. But we do have limitations in terms of metal artifact from these. You need to use special sequences to look more closely at that MRI. And then, you know, one thing that can be used and has been used in other areas of orthopedics is functional PET scans. And, you know, functional PET basically give you radio-labeled glucose or some element of glucose that essentially highlights metabolic activity. And so if you don't see anything on MRI or CT, there's no lucency, you can obtain a PET scan to see if there's any increased uptake. And this was from a case report that showed that at T5, which was the top of where they ended their AIS scoli surgery, there wasn't any lucency, wasn't any increased findings on MRI or CT, but there was increased metabolic activity, which raised everyone's clinical suspicion. When they went in, the screws were clinically loose and they had a culture positive infection. And so this is used in many other areas of orthopedics to diagnose sort of more indolent infections. I think it does have a role. I don't use it routinely. I largely use lab work, MRI, and CT, but if I'm truly wondering, especially in increased back pain where fusion looks good or there's other concerning findings, that's sort of when I go to the PET scan. And so in conclusion, you know, there's no exact recipe for diagnosing post-operative infection. You know, what I can tell you is that you really need to have a heightened clinical suspicion. You need to use the part of your brain that you still remember as a physician, and history and physical are key. These patients are going to come in with a change in their symptoms. They're not going to feel great. They're going to have increased back pain. And everything else that you do, including labs and imaging, don't make the diagnosis. They just provide you additional pieces of information which you need to take into consideration when you decide to take these patients back to the operating room. So thanks.
So Nick, two questions for you. One comes from the audience. Has there been a case where you've used procalcitonin, and if not, is there a scenario where you would use it?
So I personally have not used procalcitonin. I think it's becoming increasing in popularity over, especially in PJI with our total joint colleagues. I tend to use CRP just because I know it a little better. I think that if CRP is borderline high, I may obtain a procalcitonin level just to provide another piece of information, but I don't know enough about it and haven't read specific cutoffs other than elevated or not elevated that I can hang my hat on clinically.
The other question I had personally is, you know, it's not uncommon typically in our practices to see somebody coming back with some serous drainage within 1 to 2 weeks after surgery. In an instrumented case, what is your algorithm for that?
Yeah, so I think you highlight a good point. I'm a little bit quicker to pull the trigger on an instrumented case rather than a non-instrumented case. So if I've done a laminectomy or a microdiscectomy and there's no hardware in place, there's drainage, the wound doesn't look great, I will often start them on oral antibiotics and follow them up in a week. Depending on how much drainage and what the drainage has done over the previous couple days, in instrumented cases, if it's pretty profuse drainage, soaking dressings, having multiple dressing changes a day, I tend to take those patients back to the operating room. Before I take them back, I do obtain lab work, ESR and CRP. If they're stone cold normal and they've already normalized, I'll watch them for a week. And if it doesn't slow down, I take them to the operating room.
I'm going to get you to stop sharing your screen and
Yep.
let me. That's a great overview as well, Nick. So at this point in time, we'll talk a little bit about what you do from there. So now you've made this diagnosis. So now what? The first thing that you have to do, just as with any other problem, you have to assess the patient. And so one of the really concerning things that can occur with an infection is that that person can be presenting in septic shock. And so if they're hypotensive and tachycardic and they have pus under pressure, then the treatment of that person is obviously very clear. They need emergent empiric antibiotics to help stabilize them, and an urgent debridement to get that pus under pressure out. If they're not, which is, as Dr. Spina has already alluded to, the vast majority of people aren't presenting in that sort of extremis type of condition. And so instead, we're going to be looking to obtain blood cultures, hold the antibiotics so that you can get the best cultures intraoperatively that you can, and then set up a surgical debridement, whether that be at the end of your day or the next morning or whatever that may be. And so once you're going to make the decision to take them to the operating room, we talk about a surgical irrigation debridement, but really I think of that more as a surgical debridement and irrigation. And so what I mean by that is that the debridement is going to be the part of your surgery where you're going to obtain source control. You're going to debride all non-viable appearing tissue, including skin, muscle, fascia, and bone. You need to take out any and all loose bone graft that can be a nidus for ongoing infection. Anything that isn't going to be able to ultimately be penetrated by your antibiotics on the back end needs to come out so that you can make sure that your infection will ultimately be cleared. And then during that time, that's the point when you ultimately are obtaining your intraoperative tissue cultures. And tissue is typically better than pus in terms of the ability to get positive cultures on the back end. And that's really the important pieces to that portion. Once you've done that, once you've done what you think you can to obtain source control, that's when you go to the irrigation portion. And the recommendations are ultimately to irrigate with at least 9 liters of normal saline for a standard lumbar type wound, with the thought being that the solution to pollution being dilution. And so the more that you're able to minimize that bacterial load through your irrigation after you've done an adequate debridement, the better off you'll be. There's lots of different ways that you can get at the notion of irrigation, and you can do that with pulse lavage. You can do that with bulb syringe, or you can do it with a low pressure system like cystotubing or arthroscopy tubing. And all of those have different literature that supports one versus the other. But in the end, the most important thing is ultimately the amount of fluid that you put through to minimize that bacterial load. Once you've gotten to that place, then you have to make that decision of, well, do I retain my instrumentation or do I not retain that instrumentation? And that's been a discussion in our literature for quite some time. There was a really good review of that literature by Lal in Journal of Clinical Neuroscience in 2015. The ultimate upshot to that is that when you have somebody who has an acute postoperative infection in the setting of instrumentation, an acute postoperative infection is being described in this particular review as 2 to 3 weeks post-op, up to 3 months post-op. If you do a good irrigation debridement at that first diagnosis, and then treat appropriately with antibiotics on the back end, you can have and achieve really high rates of eradication. The flip side to that is that in that person who you acutely have treated surgically with instrumentation, you put that instrumentation in for a reason, meaning that there's somebody with a significant deformity or instability, and that instrumentation is providing them stability that they need for other reasons. And so the risks of destabilization by taking the instrumentation out is ultimately going to be higher in these acute postoperative periods than the risk of ongoing infection that the instrumentation is going to ultimately pose. The opposite is then going to be true, though, in your delayed infection. So those are the people who are going to be greater than 3 months post-op. And in those people, removal of instrumentation is going to be supported. And so why is that? Well, in those delayed people, number one, that infection is going to tend to be a bit more socked in. And so your adequacy of debridement is going to be really important. And so just taking out the instrumentation, getting around those corners to be able to make sure that you've adequately debrided. You don't have those spaces underneath of your instrumentation that you couldn't get to. if you've removed your instrumentation in that case. The other piece to it is, and Dr. Jackson's already alluded to this, is the formation of biofilm. Biofilm is defined as the syntrophic consortium of microorganisms in which cells stick to each other and often to a surface. These adherent cells become embedded within a slimy extracellular matrix that is comprised of extracellular polymeric substances. And so why is that important? Well, those biofilms in and of themselves are avascular. The biofilms are then adhered to foreign bodies, your instrumentation, that's also avascular. And so your antibiotics can't get to either the instrumentation or into that biofilm. And when you are looking at acute postoperative wound infections, only about 6% of those tend to have biofilm formation at that point. Whereas in those chronic infections, those infections that have been in those patients that are greater than 3 months out, up to 90% of them are going to have biofilms. And again, as Dr. Jackson already alluded to, the places where you're going to most commonly see biofilm formation is going to be in Pseudomonas and Staph aureus is going to be the most common organism that you see in postoperative infection. So what about interbody cages? Well, ultimately, the literature for interbody cages looks a lot like any other instrumentation in spine, where you end up with high rates of cure in acute infections. And so even though the P cages that Dr. Jackson had mentioned have that high biofilm formation, they tend to still be able to have a infection in the acute postoperative period cleared. The other question, if you're talking about something that's not put in posteriorly, something that's put in laterally or anteriorly, the rates of infection in those types of surgeries are quite low, meaning if you look at Dr. Uribe's series of 13,000 lateral interbody fusions, he had an infection rate of only 0.1%. And so your ability to study infections in lateral interbody fusions because of that low rate of infection is really difficult. But that being said, generally speaking, the anterior spine is a pretty forgiving space when it comes to infection. And what we mean by that is in times when we have a spondylodiscitis in the lumbar spine or in the cervical spine, what do we treat that with? We treat with a debridement and then instrumentation or an allograft that we place in the setting of an infection to reconstruct that area. And so the corollary would often be, well, if you're able to put that type of graft into an infected area and cure an infection, well then an adequate postoperative IND in the acute period and retaining that instrumentation probably ought to be able to clear that infection as well. And so if there is significant advantages to the removal of instrumentation in the delayed infection setting, well, what are the downsides? Particularly in the setting of deformity surgery, the loss of deformity correction has been pretty well documented. And that's in spite of the notion of there being a full bony fusion on inspection of fusion at the time of surgery. And so Hahn looked at Propriobacterium acnes infections in the late period in pediatric scoli surgeries, when those people who were already healed on clinical inspection, they had their instrumentation removed, they ultimately typically lost somewhere between 10 and 26 degrees of correction. In the adult side, Viola in 1997 looked at 8 consecutive adult deformity patients. And what they found is even though those people had what appeared to be solid fusions in the postoperative inspection, 3 out of 8 of those patients ultimately required further surgery as a result of postoperative kyphosis, either a junctional kyphosis or a postoperative kyphosis that occurred through the areas of previous surgery. And so even in the setting of a late infection that seemingly has already healed, there still are pitfalls to the removal of instrumentation. So once you've done your debridement and you're getting ready to leave the operating room, then you have to make the decision about whether or not or how to close the wound. And so typically most infections can be closed primarily at the time of debridement. That's usually done just over a drain or drains, depending on the size of your surgical field. So times that may not be possible or advisable are times of heavy contamination, if there's significant dead space following debridement, or if the person is particularly malnourished. And again, Dr. Jackson has hit on this, but the people who were malnourished prior to surgery, if that person and ends up with an infection, that person then has an infection and has been sick for a prolonged period of time as a result of that infection, their malnourishment is only going to be worse. And so their ability to heal a large infected wound is going to be very difficult. And so in these types of settings, a back and a second look, particularly in the setting of heavy contamination, is an appropriate thing. And then with lots of dead space or malnutrition, a back assisted closure by secondary intention can be a very viable option. The other thing to do in those large dead space cases is consider a plastics consultation, because a flap coverage can not only help with the dead space, but can also increase your vascularity to an area and ultimately in that way help with clearing of infection. So after you've left the operating room, treatment with acute empiric antibiotics, broad spectrum antibiotics, until we have our intraoperative cultures come back, is appropriate. For instrumented cases, I always end up with an infectious disease consultation to help guide appropriate antibiotic treatment and make sure that we have appropriate organism-specific antibiotics for the cultures that we've obtained. And again, making sure that you have not given antibiotics before your debridement and culture is really key to making sure that you get adequate cultures on the back end. And from a standpoint of duration of antibiotic treatments, when you have opted to retain your instrumentation, leaving, when you've opted to retain your instrumentation, having a prolonged course of IV antibiotics, likely 6 weeks, followed by, again, a prolonged course of PO antibiotics following that is the typical recommendation. Whereas if you've removed your instrumentation, a shorter course, only a couple weeks of each, may be completely appropriate. In terms of adjuncts, rifampin can act as an adjunct, and the reason that rifampin is cited as an adjunct is because as an antibiotic, it has a very specific ability to penetrate biofilms. Now, rifampin in and of itself is not used as a monotherapy, because when it's used as a monotherapy, antibiotic resistance is quickly developed. But again, it's commonly used as an adjunctive therapy for a case of retained instrumentation, particularly in the setting of Staph aureus, and the concern for biofilm formation, because this can help eradicate early biofilm. The last thing we'll talk about in terms of an adjunctive treatment is hyperbaric oxygen. Again, this is going to be used really only in your really high-risk patients. The article that's cited here is pediatric patients with neuromuscular spinal deformity surgery. And ultimately, the way hyperbaric oxygen works is via pulse therapy with 3 25-minute sessions with 10-minute breaks in between. That's done 5 times per week for a number of weeks in the setting of the acute postoperative IND period. And the thought of how hyperbaric oxygen works is it ultimately promotes increased oxygenation to the site of the infection, increases vascularization, and improves macrophage functionality, and ultimately also subjugates biofilm formation. So again, I don't think of that as a frontline treatment, but when you're talking about something where, gosh, I need to throw the kitchen sink at this to really get this to heal because I'm very concerned about this high-risk person, this is what you would be looking at. And so back to our patient, this is the patient that Dr. Spina had showed you with the concerning postoperative fluid collection. And so she was taken to the OR for an IND, removal of her instrumentation and a wound vac. There was known to be really gross contamination. And so wound vac and second look was felt to be the most appropriate treatment. Her cultures grew out MRSA. Again, we did end up doing a removal of hardware because, number one, she had an initial bacteria of Staph aureus that in the setting of a stainless steel implant that had a long-term infection presenting greater than 3 months out. So that prompted the removal of hardware. We ended up bringing her back to the operating room, doing subsequent INDs and wound vac changes on post-operative days 2 and 4, and then making the decision at that point not to do a secondary primary closure, but rather treat her with wound vac to closure with secondary intention. She was treated with IV Vanc for 6 weeks. Again, even though she had her instrumentation removed, the thought there was that she'd already had a failure of an IND and a course of antibiotics, and then transitioned to Bactrim PID for 4 weeks. Ultimately, her CRP at the 6-week mark was 26. The 6-month follow-up for her, she had mild recurrent low back pain throughout her course. The only complaints she ever had were really of low back pain. And so the fact that she had a little bit of increase in her back pain prompted repeat imaging. Her repeat imaging didn't show any local kyphosis or deformity at that L1-2 pseudoarthrosis level. So we were felt confident there. Her repeat MRI did not show any recurrent or persistent fluid collection, and by 6 months, her CRP had nearly normalized to a level of 10. And so from a standpoint of giving some ultimate conclusions to this talk, what I would tell you is when we're talking about post-operative infection in the setting of instrumentation, I can't agree with Dr. Spina more. These are the people who you have to treat with an extremely high index of suspicion, and you want to treat them more aggressively rather than less aggressively. The reason for that is if you treat them aggressively, you can often retain their instrumentation and still cure their infection, so you can make the best of a bad situation. In the setting of late infection, those are the people who ultimately you are going to end up likely having to treat them with a removal of that instrumentation. And then on the back end, you need to make sure you follow those people, whether you think they were healed or not, even after they've cleared their infection, to make sure that they do not end up with a late complication of the removal for their instrumentation. So with that, I will open it up to questions.
Hey, Greg, one of the questions that was asked during Nick's talk has something that has some relevance to your talk. Question was, do you have any experience with suppressive antibiotics until fusion and then removal of hardware? And when is that the move?
So, I think that it's not a question of a planned suppression, I don't think. I tend to think of it in all of those cases as you're trying to cure that person. You're debriding them and you're treating them with an antibiotic for the reason of cure. And then on the back end, if you haven't been able to cure them, that's when you end up removing the instrumentation. That person who I think you're talking about is going to be the person who is in the acute period and they haven't healed yet. And so the goal would still be not just suppression, but rather curative treatment.
What are you using incisional wound vacs in your practice, Greg?
So I use incisional wound vacs on my high-risk patients, and so my adult deformity patients, I'll end up using an incisional wound vac, and I use those in the setting of trauma as well. So really, anybody who in my practice is going to end up in an ICU post-operatively, particularly if they're going to be in an ICU for a prolonged period of time, I'll use an incisional wound vac, and I'll typically leave that in place for between 3 and 5 days, depending on the patient and the problem. Nick, what do you do in terms of incisional vacs?
So I tend to use incisional vacs on threatened wounds. So if I take a patient back for an SSI with frank wound dehiscence and the skin edges don't look good, I've used a commercially available product that stays on for 7 days. I haven't used them in the acute or kind of prophylactic setting unless it's been a multiply revised kind of 7 to 8 time failed back syndrome patient where I'm worried about wound healing. I've had great success though with those threatened wounds. I think they do make a difference. So it's more of a cost issue to use them routinely in my mind.
Then Nick had mentioned in the setting of a stitch abscess, his go-to is treatment with observation, no antibiotics. Is that what you're doing, or are you using PO antibiotics in the setting of a stitch abscess?
You know, a lot of times I'll, if I'm convinced that it's not anything deeper or more worrisome, such I'll get labs and make sure it's normal. And a lot of times I'll go ahead and open it up and treat it locally. I'll treat it with the oral antibiotics, but I think I'm trying to prevent a sort of super infection more so than I am actually trying to treat a local infection. So that's kind of my thing is if they're spitting out, if they've got a little area of dehiscence with a little bit of drainage, I'll go ahead and open it and try to just do a little local IND. I'll probe it to see if it goes deeper. If it does, then we've got a problem that I don't think we can address in the clinic. So that's, I previously, you know, in the first couple of years, I took a lot of patients back that I wouldn't right now. I think I've sort of learned a little bit of tincture of time, and I've been burned a few times, but most of the time, I think, yeah, most of those patients with the benign, more superficial things can be managed as an outpatient without a return. What about you?
So again, I completely agree with you. I think that a lot of it depends. I'm pretty aggressive in getting labs, as you suggested, and when the labs look pretty benign, then I'm pretty convinced that it's a superficial wound issue. I do use antibiotics. When I have any concern that it's going to be a deeper wound infection as the real issue, giving antibiotics, I think, clouds the picture of your intraoperative cultures when you end up having to take them to the operating room. And so that's where I think just routinely giving antibiotics is a bad idea. Listen, guys, I've got 9:02, so we'll keep moving here. Our next AO Spine webinar is on multi-level cervical stenosis, laminoplasty versus posterior decompression and fusion. That's going to be on October the 28th, same time. It's a Wednesday, 8 p.m. That's going to be led by Dave Oystein, and it's going to also include faculty to include Dr. Herzog and Dr. Agachukwu from Augusta University. Again, I want to thank our panelists. Thanks again to Nick and to Lynn. I appreciate your time, and it's always great to get to talk to you guys. And I appreciate all of the participants being involved tonight for what I think was a really great one. So have a great night.